Right.
Okay.
Okay, share.
Good afternoon from Chicago, everyone. My name is Mary Bunn. I'm a faculty member in psychiatry and a core faculty member at our UIC Center for Global Health. And on behalf of the Center for Global Health, want to welcome all of you to today's meeting. Before we talk about today's presentation, the role of lived experience expertise in global mental health, I want to also just take a moment to ask you to save the date for our December Global Health Colloquium, which will be on December 4th, on the topic of a talking, teaching, relational avatar promoting antiretroviral adherence and retention and care and a mobile phone app. Jeannie has just sent the flyer for that colloquium through the chat here, so I hope you'll all save the date. So without further ado, let me introduce today's speaker for all of you today. I'm honored to introduce Charlene Sunkel, who's joining us today from South Africa. Charlene is the founder and chief executive officer of the Global Mental Health Peer Network and a leading global advocate for the rights of individuals with mental health conditions, drawing from her own lived experience of schizophrenia. Charlene has made significant contributions to international mental health research and practice, including authoring numerous papers from a lived experience perspective. She served as a commissioner on several Lancet commissions, including Global Mental Health and Sustainable Development, the Future of Psychiatry, and co-chaired the Commission on Ending Stigma and Discrimination in Mental Health. She's editor-in-chief at PLUS Mental Health, and previously she was a member of the South African Presidential Working Group on Disability and the Ministerial Advisory Committee on Mental Health, and served as principal coordinator for the Movement for Global Mental Health. Her work has been recognized with numerous national and international awards, including but not limited to the Swiss Foundation WHO Outstanding Achievement in the Field of Mental Health. For me personally, Charlene has become a trusted mentor and collaborator, and I'm grateful to her for joining us today to talk about her work and the important topic of lived experience in global mental health. Before I hand it over to Charlene, a few housekeeping bits I forgot to cover. We're going to accept questions for the discussion portion of today's presentation via the Q&A feature of Zoom, and we'll only be accepting questions via the Q&A. So please, as questions occur to you, send those along. So without further ado, let me hand it over now to Charlene.
Thank you so much, Mary. And really, it's a nice opportunity for me to talk to you today. So let me just quickly get to my slides. There we go. I hope you can see that. Okay, so I'm gonna dig right into it. I maybe want to emphasize the Global Mental Health Peer Network. We have a slogan, unapologetically experts by experience. So talking about kind of emphasizing that lived experience expertise that we have, that we can contribute to the global mental health space. I think essentially, if we look at the role of people with lived experience in global mental health or global health even, is to base it on we are all equal. I mean, we got equal rights, we got equal right to access health and mental health care services, but also equal right to have opportunities to contribute to the sector. What we've seen over time, and for me it's particularly visible if I look back, reflect on when I was diagnosed with schizophrenia, that was 1991. And if I look back to and to see where we are today, it's really visible to see the paradigm shift that's been happening over this time. I think 20, 30 years ago, I would not have been sitting here talking to you because my expertise would not have mattered or been recognized at all. There was always this us and them phenomena. So it's always like that big divide between service user and service provider. But we do see now how people with lived experience are increasingly recognized as key partners and no more just as objects of care. What we also see, and there's really a lot of momentum happening, especially in the last couple of years, where people with lived experience are involved much more in policy, but even for me, I can see more in terms of research. And again, not as research subjects, but more as contributors to research and bringing that expertise. and service delivery, and also service development. There are actually numerous international documents, including conventions, reports, guidelines, that really emphasize the value of lived experience inclusion across different sectors within the mental health space. And it really promotes and emphasizes to be more equitable, that it's more rights-based approach and person-centered, and that people with lived experience, of course, can help advance that agenda. Just to mention a few key documents. First of all, I'm not sure if you are familiar with the UN Convention on the Rights of Persons with Disabilities. We use that quite a lot in terms of advocacy because that specifically also emphasize the value that people with disabilities, and including psychosocial disabilities, can contribute, and also contribute to the overall well-being and diversity of communities. It also emphasizes a lot on full participation in society, and that can, of course, result in enhanced sense of belonging and significant advances in both human, social, and economic development in populations. Then we have, it's fairly recent, the WHO World Mental Health Report. The theme for the latest version was on transforming mental health for all. Many of our members of the peer network participated in the development of this report. I don't know, you can always access it on WHO website. And you will see they used a lot of, quotes of their experiences. And that's always so valuable when you kind of see the real experiences at grassroots level versus kind of, if I can say, theory and what policies say. So the report again speak of people with lived experience to be crucial stakeholders and the importance across mental health systems, services, and outcomes. And I think what's important from this report that it also emphasizes full empowerment and involvement. I mean, for me, the factor of empowerment is very important when we move towards integrating people with lived experience in this mental health space. Because stigma and discrimination has really caused so much oppression, if I can put it that way, and really put us behind. And without empowerment, it's very difficult to ensure that people are able to meaningfully and authentically be involved. A document that actually followed the World Mental Health Report is the framework on meaningful engagement. And that specifically speaks to non-communicable diseases and mental health and neurological conditions. And again, emphasizes the importance of engaging people with lived experience. Sustainable Development Goals, which is a bit more older than the previous two documents, that also emphasizes that. And when we're in the mental health space, and especially advocacy, we basically use these 4 documents as really tools and guidelines for our advocacy initiatives. I'm going to speak about the different ways in which people with lived experience play an important role. I'm going to start off with inclusion and stigma reduction, because stigma is often such a barrier in accessing mental health and healthcare for persons with lived experience, and it of course also creates barriers when a person's trying to access other life opportunities like work and employment, education, housing, and all those other opportunities that other citizens do have access to. Mary mentioned my involvement in the Lancet Commission on Ending Stigma and Discrimination in Mental Health. yeah, this is a prime example of co-production. There was various ways in which people with lived experience were involved in the development of this report, but I'm not going to go too much into that. And just to maybe mention this image, the cover image was an artwork of one of our members from Indonesia. And he was depicting his experiences of stigma in mental health. From the Lancet Commission, we set 8 key recommendations and targeted at different stakeholders. Although these recommendations are targeted at different role players, people with lived experience, of course, play a very important role across all of those 8 recommendations. Recommendation 1 and 2 specifically speaks about countries needing to reform their mental health policies, plans, and laws to really eliminate stigma and discrimination. And it also speaks about an evidence-based practical toolkit that needs to adapt to local context. Now, that toolkit has already been developed and it was recently launched. I'm sure you can find it on WHO website. It's called Mosaic. That's that toolkit. Some of our members were involved in the development of that as well. And that actually speaks to what I'm trying to say of how people with lived experience can actually be involved in these 2 recommendations, specifically by being involved in the adaptation to local context, and also to check whether terminology is used in a non-discriminatory way. Recommendation 3 focuses on legislation that needs to be repealed that perpetuates stigma, discrimination, and human rights, and especially the decriminalization of suicide. There's many countries still that criminalize suicide. And it really puts a criminal element on mental health as a whole. So people with lived experience play an important role in that process by helping to guide governments in evaluating and monitoring legislation in terms of these aspects. Recommendation 4 was focusing on mental health at work. World Mental Health Day in October, 10 October. This year was actually focusing around mental health in the workplace. It calls upon employer organizations to implement guidelines that was developed by WHO on mental health at work. So people with lived experience, of course, play a important role here in supporting employers, but also governments to promote mental health in the workplace and align mental health policies and guidelines. Recommendation 5 focused on evidence-based sessions on stigma reduction to be mandatory to pre-qualifying courses for health and social care staff. And what's very important here and that we advocate quite a lot for is that people with lived experience should be involved in the delivery of training of all health and social care occupations and professionals. And we actually have seen quite a lot of increase in that, where we have delivered like lectures to psychiatrists as well, which is actually very essential because even psychologists and other professions in mental health, because theory is very different from actual experiences. So the value that people with lived experience bring in terms of delivering training is to bring the human element to it. And the Lancet Commission, one of the key findings is that one of the most effective ways of breaking down stigma is through social contact. So having contact with someone with lived experience. Recommendation 6 was focusing on policy statements and action plans in terms of the media. because the media play a very important role in stigma reduction. As you know, if they report in a negative manner or inaccurate way, they can do a lot of harm in terms of stigma. But if they really put a positive spin and really report accurately, they can help break down stigma. And people with lived experience can be involved by consulting with the media in developing their statements and plans, but also to check if they report accurately, especially in terms of terminology used. Recommendation 7 and 8. That speaks more about people with lived experience that need to lead or co-lead anti-stigma efforts and also need to be supported through providing mutual help, peer support in peer support networks to integrate people as providers of health and social services, and also to receive support when disclosing and how to disclose. So the Global Mental Health Peer Network leads these recommendations, and we have partnered with Stellenbosch University in South Africa, and we run an annual survey to really get feedback from people with lived experience, but also family and carers, as well as professionals, so that we can kind of determine at grassroots level what the progress has been in terms of stigma reduction, but also attitudes in service delivery, in mental health care, policy-related issues. And that really also reflects on when countries report to WHO or the UN in terms of progress made on legislative matters, and it just brings that value of real experiences. Inclusion in research, as I mentioned, that kind of booms quite a lot right now. At the Global Mental Health Peer Network, we have an Experts by Experience consultancy services unit where we deliver services, and one of the services components that we do deliver is collaboration in research. And I must say it's grown significantly over the last year, I would actually say. And the emphasis there is to really involve people with lived experience right from the beginning. From developing research questions to plan, develop and implement a project, data collection, analysis and interpretation, dissemination, and most importantly, actually for me and especially for the network, is applying research to advocacy. Because if we advocate for improved services or to implement best practices, and we address government to implement something like that, they would always ask for evidence on how it works, how it would work. And so applying, so using research to really strengthen our advocacy goals is really important. So for us to be involved from the beginning to that end is always important. And then inclusion in policy reform. Yeah, I think probably the most important thing about the function of policy is to respond to the needs of people and to protect human rights. So by saying this, it's almost like a no-brainer that it is important to include people with lived experience in policy related to mental health. Because how otherwise are you going to really know the needs and challenges that people at grassroots level experience, and also how you can protect their human rights? When we do include people with lived experience in policy, the end result would be that human rights are respected and protected. We'll see that services and support is of high quality. We'll also generate trust and confidence in the system and improve engagement with care. And essentially, it is cost-effective service delivery. If professionals, without having that lived experience, expertise, or experience, develop a service, you may not necessarily think of all the angles that someone who's navigated the system, who's experiences the difficulties with the condition and the system, you may miss things. And it's always important from that angle, from the lived experience, to guide what services would be beneficial for the majority of people with lived experience or experience mental health conditions. In that way, it would be far more cost effective, because you're not going to spend money on something that may only serve a minority and not the majority. And then inclusion and service delivery. This at the moment is happening more so in high-income countries, where we see a lot of dedicated positions created for people with lived experience within the mental health system. Just some of these peer specialist titles that we come across is like peer support workers, peer mentors, well-being coaches, lifestyle facilitators, recovery workers. I discovered quite a lot of different titles, but it's formalized positions within the mental health sector. This is not something that you actually see in low and middle income countries. For example, in South Africa, we do not have even the basic peer support workers. And that's why it's important for us to be involved in policy, to emphasize how important peer support, for example, is. Because in South Africa, there's also a human resource scarcity in terms of mental health. Now, just imagine how that gap can be closed by implementing peer support workers. So, yeah, you need a lot of patience when you try to implement something and when you work with government. But, yeah, it takes time, and then we will get there. But there are, of course, barriers to inclusion of people with lived experience. What we found through our work and through the organization and through discussions with our members, I've categorized 3 key obstacles. First of all, it's stigma and discrimination. That's really devaluing our personal collective experience. We've come across a lot of issues or feedback that there's this misperception that someone with a mental health condition cannot contribute because of the limitations of their mental health condition or the symptoms of that. There's also another misperception that we are unable to make decisions. And I can actually say more so for schizophrenia, you'll see that that's often the issue. Okay, not everywhere, but to some degree in countries, especially more in low and middle income countries. So especially in policy making, it's sometimes seen as people are not able to make decisions or partake in decision-making processes. Then there's the ever-existing paternalism and power imbalances, the us and them, as I mentioned before. Sometimes when we look at paternalism, it's often done with the best of intentions. Someone really want to make decisions or help you make decisions to the best they think how. But sometimes it's very disempowering. And the whole power imbalance as well. It is very disempowering. And ultimately, we need to empower people so that they are able to meaningfully contribute. And then, as we've seen the shift towards inclusion of people with lived experience, we often come across stakeholders who are very open to say, we really, really want to include people with lived experience, but we do not know how. So people don't understand exactly the role of lived experience at various stages of a project or research or so. Sometimes there's a bit of, how can I say, a perception that you need a qualification when you're involved in research. That's kind of quite a big one that we often see. but it's not necessarily. I think the important thing to understand is we're not coming from an academic background. We're bringing lived experience expertise. That is the expertise that we bring. There's also concern about ethics, and I think especially that comes from perception from a research angle, where when you do research with people who are vulnerable, that you need ethics approval and follow those processes. But if you really think of it, if a person or persons with lived experience bring their expertise, essentially they are consultants, they service providers, they contribute as an expert in their field. So it's not necessarily like for a, let's say, a psychiatrist who kind of are engaged in policy, for example, or in research, to have ethical clearance. So again, coming back to the equal, we are all equal. And then there's also concerns about the impact on mental health that may be relevant, especially if we bring our lived experience expertise, especially in projects where we need to think or relive certain past experiences that may be triggering. But there are, of course, ways of overcoming that. I can use an example, what we do. When our members participate in our service delivery, we always make peer support available to them should they get triggered throughout any of the processes, that they know there are support available to them. And then neglect to adequately budget for lived experience inclusion. We found that a lot, but we do see some improvement in that aspect. We are developing a costing model for lived experience remuneration in different roles that they take on. So I think it comes from a past assumption that people always do this in a voluntary capacity and not always considering the cost to the person or the organization, especially in terms of usage of data. Especially in African countries, data is extremely expensive. And sometimes when it's an individual, they may live on a social grant, but yet still bring their expertise. And then there's often also not considering of the value of the specific expertise and the contribution to the outcomes of a project and the benefit of that, the value component of that. Just to mention some of the key elements that we recommend when engaging with people with lived experience, always to include people from the very beginning. And I mean from planning projects, the strategic development, the conceptualization of an idea and initiatives, the monitoring and evaluation phases as well. What we found, we see, because there's improvements in terms of that, but sometimes we've been dumped in the middle of a project, and it can be very demotivating because remember, many of the people has already been there from the start. So yeah, you come in the middle and you have to catch up, and you haven't followed everything. So you feel a bit lost and you feel like an imposter. So it can be very disempowering. So that's why we always recommend to include people from the very start. And then to also be very clear about responsibilities and expectations, especially in terms of information and communications to be provided in advance. For example, be clear about the project, what it's about, defining the roles and responsibility of the person, what is expected of them, time, expectations, basically all the information. What we do at the network to facilitate this aspect, and also to help with meaningful engagement, because we want to deliver quality and meaningful contributions, is we host, before we do an engagement or deliver a service to a client, we have an orientation session with our members who are involved. There's often about 10 to 15 members involved. And that is an opportunity we use to give information and also give opportunity to members to ask questions. So they go into this project fully informed, know what it's about, know what their role is, and what to expect. And that is when you really can say a person can provide meaningful contributions. Promote well-being, reasonable accommodation measures that we also advocate for. We do have on our website a document about reasonable accommodations. And by that, since we work globally, we always have issues with time zones. So if you have a project that is global, to consider time zones, but also to consider aspects in terms of medication. Like my medication, I literally take 2 hours in the morning to be fully alert. Although I'm awake, I'm not fully alert, and I wouldn't quite make important decisions at that stage. So I'm not going to contribute meaningfully at that point. So consider those aspects as well. But of course, it's always important to ask the person. And the space also need to be safe and engaging for the person so that they feel quite relaxed and free to give their expertise. Resource and support. That is what I spoke about, remuneration. And then principles of engagement is, of course, there needs to be no power imbalances to limit the risk of conflict. And then also the principles that value respect, responsibility, accountability, anti-discrimination, equality, equity, all these nice things. And that goes both ways to be applied to an engagement space. I think this is my last slide, if I'm not mistaken. We also developed consult guidelines, and this is just to kind of summarize what it means to integrate experts by experience meaningfully and authentically. First of all, as I mentioned, to create safe space, to obtain diverse representation of lived experience, to enhance equality and inclusion, and maybe to just speak a bit more about that. I'm going to speak about, use an example of in South Africa. Like government would often, let's say, only call on me to be part of review of policies and legislation. I don't feel that's right because I can't speak for the younger generation. I can't speak for another person, let's say Black people. I can't speak for men. So that diversity is always important to also consider, to include youth, LGBTQ communities, whatever. If you really want to build something that's made of quality and have contributions that made for a whole population, it's important to have that. And then no power imbalances, which I already spoke about. And of course, maybe just to mention tokenism. Tokenism, we still see happening quite easily, especially with all those documents I mentioned that kind of give a bit of a push to include lived experience. Sometimes it becomes then a tick box exercise. There must be mutual respect. That's to sustain that. I spoke about the upholding of the principles of effective engagement, and then to really leverage lived experience expertise. Really make use of it. And I think that also comes back, not when tokenism happens, then you don't really leverage the lived experience expertise. And the last one is transform policy and practice that accurately reflect lived experience voices. It is very discouraging when when you contribute or you give your expertise, let's say again, to a policy or a document, and at the end of the day, you find out that none of it's been actually used or added to this document. So whatever you said was not valued enough. And I think that's especially relevant to experiences in policy. Yeah, okay. I don't know how much time, but I think I left some time, enough time if there's any questions that you may have. So I'll just stop sharing here. Okay.
Charlene, thank you so much for that wonderful talk and taking us through, sort of where are the state of things in terms of integrating people with lived experience into the full spectrum of policy, service delivery, research. I want to open it up now to our audience for question and answer. And I wanted to start by allowing one of our colleagues, Don Ziegler, who posted a question to the chat. We wanted to give him a chance to ask his question directly. So Don, oh, there he is. I think Jeannie is working behind the scenes now to make this happen.
Hello.
There we are. Thank you, Don. Yeah, I wanted to give you a chance to ask your question directly to Charlene. Thanks for including it.
Okay, wonderful talk. I appreciate that. It's a very important topic. You gave some examples mostly from South Africa, but can you give some other examples at national or subnational level of best practices? Who's doing this well from across the world, if you can?
Oh, thank you, Don. Well, I think to some degrees, I don't think there's a country that really does it very well, perfectly. I think it's an evolving concept. I think integrating lived experience still, if I can say, a new concept. But high income countries, I know the US does a lot, but of course there's hiccups in all of the aspects. Europe, Europe and UK, I would say I can't mention specific countries. I know Denmark is one that really does well. But of course, there's always some degree of things. And I think we learn a lot from as we implement these things and going along. I know, especially in terms of peer support, I often hear almost the same story, same complaints across, like, I would say, America's regions and Europe regions. But I think it's important to take what's learned from those experiences, especially if I mention like peer support. I hear a lot that sometimes when it's integrated within the mental health system, that there's some resistance from mental health workers or the professional side to work with the peer support workers. But I think the failure there is that there wasn't training done for the professional staff, because this is something completely new, you can imagine. So there will be some resistance. So I think we need to come up with solutions and learn from that. And I think in middle income countries where it's not done, we can actually learn from the high income countries where it's done and gone through the hiccups, if I can call it that. I hope that answered your question.
Great, thank you, Charlene. There's a question that came through in our Q&A that I don't know that everyone can see this, so I'll just read it to you out loud. And this is from one of my colleagues and team members. Have you observed any differences in the trends of using experts by experience across different countries? For example, are organizations more or less open to using experts by experience in some countries more than others?
Yes, definitely. I think in Africa, it's actually quite from my observation. I can speak from my observation. I do see, I think America is, from my observation, is very open to that. It's almost like it's acknowledged, it's integrated. I think you can actually see it from once it's integrated into a mental health system. Because for me, then it tells you that it's recognized.
Mm.
In African countries, it's not. Sometimes you more will see a NPO or NGO organization, a non-governmental organization, that may have implemented a project related to using peer support workers. But that still doesn't make it that it's recognized by government. So I think for me, that's an important distinction. In Africa, you still see there's a lot of stigma. They find it very difficult. I can maybe say, I once asked, let's say, one of the psych nurses in one of our local clinics sometimes back, because I trained some of the service users through empowerment sessions. And I asked, can we have one of the service users use the clinic to provide some peer support? And her response was, they're not qualified to do it. There's no way that a person with a mental health condition can deliver a service. It's just not. So there's still that perception. So I think sometimes we think that we first need to break down stigma. But we've been breaking down stigma for many years. So the alternate solution for me is integration into society or into community is so important, because you automatically break down stigma by including people. And I think training and accreditation of these roles is very important, especially when it comes to service delivery. Because let's say that nurse who said, you're not qualified. If a person produced a certificate that they completed training in peer support, it might have had a different response. So that is a way of changing people's mindsets. I think we still got a long way to go for low and middle income countries, but I do see some changes. Some countries are more advanced. Actually, India, for me, is more advanced in using peer support.
Yeah, great. That's helpful to hear your thoughts about that. I have a question for you, Charlene, which is that, I understand what you're saying in terms of we haven't seen, let's say, systematic integration of peers globally in all settings, but in global mental health, especially in work with refugee or displaced communities, there's been a lot of focus and research on testing models that are delivered by peers or community health workers. But it seems like a real outstanding question for us is, how do we best train, supervise, and support these peer providers long-term to ensure not only that they deliver the intervention as intended, but some of the things you talked about to ensure self-care, to ensure well-being on the part of the peer provider themselves. So I guess I wonder, just based on your work and your experience, if you might speak about what you think are some of the more important elements to an approach to training, supervising, but also sustaining peer workers long term.
Yeah, I think sustaining, for me, the training component, evidence-based training component is important. To find an recognized training model across, and that's also, of course, consider it to the context. Like you say, like refugees may have a different training type, but something that's also more comprehensive. The other aspect for me is also financial investment in peer support. I think for a peer support worker to receive a minimal amount paid for their service while they make a significant impact on the outcome of mental health conditions is very demeaning. I think that, because if you really look at it, it's not that it's throwing a lot of money. I mean, how much money is spent on psychiatric hospitals? Well, we all know that research show that peer support workers can benefit in terms of keeping people more into the community and out of hospital, decreased medication, better outcomes for recovery, which in turn in the long run saves money. So why not invest in that type of service delivery and the training thereof? Why is it not a training course in university, for example? Like a nursing course, social work course, or whatever it is. It should be a profession with the same training as a speciality. I think that's the only way we really will sustain it going forward.
Yeah. Charlene, we now have another question. Steve, please go ahead and ask your question.
Can you hear me?
Yeah, we can.
Okay. Hi, Charlene. Thanks so much for being here today. And hi, everybody who's joined us. Couple things, a couple notes, Charlene, and then a question. One, big believer in peer intervention work. We have included peers in major roles in service delivery and in other research roles in several projects in several LMICs with great success. And also we have a global mental health R25 training that you're involved in too, that we really greatly appreciate the involvement that peers have brought to that whole experience. Can't imagine doing that without them, actually. And then my question is this. Not going to name countries, but I've experienced this, and I've heard about it from my colleagues, and I'm worried about it happening again. But the experience is kind of like what you were alluding to. We do a peer intervention, which is at the end of the day very cost saving compared to what it would cost if you had specialists delivering that intervention. And then the say the intervention works, it's shown to be effective, it's shown to be cost effective, and then the host country doesn't continue it and doesn't continue to make the peers a part of the system. And they say things like, well, we don't have peers as part of our system. They're not healthcare workers, and we can barely afford the workers that we have. And so we're not going to introduce new people into the system. The only way that we could support this kind of thing is through international funds. And yet we know those international funds are not sustainable. So I guess what can we do about this problem? And one of the things that somebody suggested in like a moment of frustration was have when the contract is signed, with the research funder or with the service agency, whether it's in the US NIH or USAID, to put a clause in there that they're agreeing to continue the delivery with peers. Because otherwise, it's very frustrating, especially when your project is successful, to see it kind of dropped. So any thoughts on how we can proceed, what you've learned in other countries where your team has worked? Thanks.
Thanks, Steve. Totally agree. It is actually very sad when a project ends in a country and so goes the, peers, and especially when it was successful. Yeah, it is so difficult to kind of convince, especially like I spoke about, like difficult to convince governments sometimes in some countries to incorporate that. But I do agree with you to include a clause in a grant, and with a partnership, a local partnership. Because I think essentially to also develop some kind of sustainability aspect when we have peers continuing in that country, or whether they attach to an organization, for example. Even if it's like, how can I, service users using that service to pay, a minimal amount. If there's some kind of way to build revenue to pay those peer support workers. But for me, I think the ultimate solution would be to incorporate it into formal education platforms, because then nobody can dispute it is a profession that requires a place within the system. And I know government sometimes, especially with, I think, Africa, they like to say that we don't want to implement, they don't like taking stuff from high income countries because they say it's not contextualized. So that's why I think it's important. I'm not sure where your project was done in which countries, but that evidence that it works, and to build a cost, I don't know what, research about cost.
Yes.
Yeah, the cost effectiveness into the project.
Mhm.
Because if you can prove to a government that it's cost effective and you've done research on that, I think you stand a much better chance to convince them to continue with it and to integrate it.
Thank you. I have a follow-up question. So there are peers in the mental health and psychosocial field, like we're discussing today, but there's also peer interveners in the area of substance abuse and alcohol programs. There's peer interveners in the area of HIV/AIDS programs. And many of the same countries that we're trying to implement mental health peers programs, there's these other kind of peer programs. And I don't think there's parity or equity between them necessarily, judging from some of the examples that I've seen. So how are we doing? I'm just ask you, like, how are we doing with mental health peers uh, programmatically compared to the HIV field and the substance abuse and alcohol treatment fields?
Yeah, that's a difficult one. I think we can learn a lot from the substance use component of their support in terms of groups, peer support groups. But if you ask me, to be honest, I've never heard of, for example, a, let's say, HIV lived experience person who's in a formal position, if I'm not making sense. I think I actually think we're a bit more advanced in terms of mental health, of having lived experience in more formal roles. We see people with HIV or people with substance abuse, or let's use HIV, is more on the advocacy aspect of it. In my view, what I've seen with substance use is a lot of strength in terms of peer support models and building a community and supporting each other. But if I think of, lived experience in mental health, for me, it's a bit more advanced in terms of formalized roles that lived experience play. I don't know, that's my observation. I don't know if you have any views on that otherwise.
Well, I wonder, Charlene, there's another question in the chat that to me is kind of related in a certain sense, because the Ivan who's joined has drawn attention to peer specialists, especially in the US in the Department of Veterans Affairs. And just he mentions that they've used peer specialists, especially in mental health service line, and that it especially helps to break through the trust deficit sometimes with military veterans receiving mental health treatment. So the question is, what is your take on trust building for patients or clients or consumers when served by peers in South Africa?
Yeah, I think that will definitely resolve a lot of issues and engagement with care. Because to be honest, I'd much rather have a person, a peer, and I actually in the past, although I didn't realize it at the time when I was in hospital and so, that I did receive peer support, unintentionally, if I can say that. And that, if I think back to my recovery journey, that was the most valuable. I could trust that person. I think especially if you're in a country where you have a very heavy focus on a medical model, and which is like psychiatric hospitals, institutionalization, that type of thing, then you're not so trustworthy of a system to go for care. And it's often associated with, you being crazy. And although stigma is lessened a bit, but it's still that association. And I think you can easily relate and trust a peer, because that peer is taking their own lived experience. They don't have any intention, if I can put it that way, to force certain aspects of care onto you, which you don't necessarily want. I think it's the autonomy of it as well that makes it trust, building that trust.
Yeah, and sounds like such an important entry point for so many individuals who might not otherwise be inclined to access care. It looks like we have one other question that I'll ask you to respond to, Charlene. This comes from Adriana Ramirez Islas, and she says, we know that stigma comes with age sometimes. Certain generations are less inclined to recognize mental health as an important issue to address. How can some generations be helped when they have lived with stigma their whole lives?
Yeah, I do agree. Some generations, older generations, because you're set in your ways and it's very difficult to change at that point in your life. But I think that is where the value of peers come in, especially another peer of that same age group or generation could really make that impact. Because if you're going to have let's say a young professional, young person trying to change an older person's perceptions around stigma, you're going to have a really hard time doing that. So you need to respond to that generational, there mustn't be a generational gap if that makes sense. Sorry, I'm slagging on the concentration. Yeah.
No, it makes so much sense. Like to think about that it's another dimension of lived experience is kind of being in a similar developmental or life stage as the person that you're working with. And in certain instances that might be a really important piece of the perspective that you bring that allows peer support to be meaningful, to be effective, to allow engagement. I think that's something that's maybe not often given a lot of consideration in terms of, we think a lot about past experience, maybe with a mental health condition or experience accessing services yourself. But what about these other intersectional qualities, race, ethnicity, life stage, etc. So I think that's a really helpful point to add.
Absolutely.
Yeah, well, it looks like we've come to the end of our audience questions. And so I just want to thank you so much, Charlene, for joining us today and sharing all of your experience and expertise. Such an important presentation, such an important time to really elevate this topic of lived expertise. So thank you so much on behalf of our Center for Global Health and our UIC community. Thank you for joining us all the way from South Africa.
Oh, thank you so much for the opportunity and the questions and listening to me. Have a lovely day.
Thank you. You too.
Bye. Bye.